Good morning, everyone. In the 15 odd minutes that I have, I'm going to talk about the role of MRI brain in early lung cancer. So stage 1, 2, and 3A of non-small cell lung cancer and limited stage small cell lung cancer are considered as early stage lung cancer. So whom should we scan? As per the guidelines, NCCN, ESMO, and ASCO, they all recommend screening for brain metastasis in stages 2, 3, and 4 of non-small cell lung cancer. And NCCN guidelines also recommend that in stage 1B, if it's a large tumor centrally located, then also MRI brain should be undertaken for screening of brain metastasis. And all patients of limited stage small cell lung cancer should undergo screening for brain metastasis. From the clinical and imaging point of view, all the neurologically symptomatic patients, they should undergo MRI brain screening irrespective of stage. And it has been seen that younger females who are non-smoker, they are more likely to undergo brain metastasis. And hence, this is a target population where MRI brain should be done at an early stage. From the imaging point of view, studies have shown that hilar lymph node involvement and purely solid lung nodules, they are more likely to undergo brain metastasis as compared to the pure ground glass nodules. Coming to the types and molecular profiling. So the anaplastic lymphoma kinase rearrangement, the ELM4, EGFR mutations, and CROS oncogene 1 mutations of non-small cell lung cancer, they have greater propensity for causing brain metastasis, and they all should undergo MRI brain at an early stage. Now, why do we need an MRI brain to be done at an early stage of presentation when we know it's an early stage lung cancer? Because approximately 60% of the patients are asymptomatic. And it has been seen that in T1N0 stage, approximately 3%, they turn out to have brain metastasis. And so is the case with stage 1 and 2 of non-small cell lung cancer. So if an MRI brain is done at an early stage for these patients, then these at least 3% of the patients would significantly benefit and will have a change in the management plan, which could change from a curative to a palliative intent, or both can be a curative intent at the thoracic disease level, or even the brain mets can be operated out. And we also should remember that patients who are asymptomatic for brain metastasis at presentation, but who harbor brain metastasis on MRI brain, they tend to have a poor quality of life. So prognostication point of view, it's also important that MRI brain be done at an early stage. Now, and follow-up, those patients who undergo targeted therapy, they have increased overall survival. And it has been seen that this prolonged survival is responsible for high incidence of brain metastasis in such patients. Also, those who are treated non-small cell lung cancer, and although they have not had brain metastasis at the beginning, but they have EGFR and ALK mutation positive, they also should undergo an annual brain MRI on follow-up irrespective of neurological symptoms. Now, coming to the interpretation, we use the RANO-BM criteria for measuring the brain metastasis. So as per this criteria, measurable diseases on contrast enhancing lesion, which is at least 10 millimeter in longest diameter, visible on 2 or more axial slices, and at least 5 millimeter in diameter perpendicular to the longest diameter. So anything less than this size is non-measurable, along with any non-reproducible borders, lesions, which are dural metastasis, bony metastasis, leptomeningeal metastasis, and which are purely cystic, non-enhancing lesions. They are all non-measurable but need to be documented. And as per RANO-BM criteria, we need to mention 5 target lesions in the brain. Unlike in RECIST 1.1 for other places where 2 per organ should be mentioned, in RANO-BM criteria, it is 5 lesions in the brain that should be mentioned. Now, based on location, most of the metastases tend to occur in the anterior circulation. So cerebrum harbors at the maximum, and areas having abrupt decrease in the vessel diameter. For example, in the gray-white matter junction, we see maximum number of brain metastasis, and at the distalmost areas of a vascular territory, that is in the watershed location. So brain metastasis tends to occur in the gray-white matter junction and in the watershed territories more. And we also should remember approximately 50% of the brain metastasis from non-small cell lung cancer is solitary. Now, based on appearances, cystic brain metastasis is seen in EGFR and ALK positive mutations, and hemorrhagic metastasis are also known. Now, let's look at a few examples. So, studies have shown that in most of the ALK positive mutations, they have T2 hypointense peripheral solid rim showing diffusion restriction and thick rim enhancing with infiltrative margins. So let's have a look at this example. This is a T2 weighted image. You can see that the metastasis located at the gray white matter junction. It has got some protrusion. It's got an infiltrative margin. On T2, the margin is hypointense, that is dark. This is a diffusion weighted image. It shows bright over here. On ADC, it is dark, suggesting it's a diffusion restriction. And there is a thick peripheral enhancement. So this is, most of the studies have shown that ALK positive adenocarcinomas show this kind of an appearance. Now, about the ALK negative mutations, they have got well-defined margins with uniform or patchy enhancement, and a specific point over here to notice, they have got central diffusion restriction. As we can see over here, there's again a well-defined margin, well-defined lesion with central bright area on T2, which is again bright on diffusion and dark on ADC, suggesting there is a central diffusion restriction, and peripheral, that is rim enhancement. Now coming to EGFR mutation positive, again they have got fuzzy and infiltrative borders on T2. As we can see over here, again this is located at the gray-white matter junction. So we can see an incomplete T2 hypointensity, which is central bright. Again, the periphery shows diffusion restriction, and you can say peripheral enhancement. And in EGFR negative mutations, just like ALK negative mutations, they have well-defined margins and focal restriction on DWI. As we can see over here, they are well-defined margins. They have peripheral restriction and more or less solid pattern of enhancement with a tiny central necrosis. Now, from the treatment point of view, we need to mention the number and the size of brain metastasis, because that is important for response assessment. So systemic and targeted therapies are generally given for multiple asymptomatic brain metastasis, and the IANO recommends that mets of 3 to 3.5 centimeter in diameter should be treated with SRS, and those having a limited number of mets, say 1 to 3, should be operated out if extracerebral disease is under control. And if a single metastatic lesion is located near the skull with acute life-threatening features seen on MRI, which could range from hemorrhage, hydrocephalus, brain herniation, and mass effect, then surgery is the treatment of choice. So we should mention the number, size, any acute imaging features which are there, which will all have implications on the management. Now, leptomeningeal metastasis is more common in EGFR and ALK gene mutations. And when we see on a contrast enhanced MRI brain, we see leptomeningeal enhancement, then we definitely have to do a spinal cord MRI as well to look out for spinal leptomeningeal enhancement. We can see over here, that's a very classic case of leptomeningeal enhancement. So these are the cerebellar folia, which are very prominent, thick, and enhancing. As you can see, the strands radiating. And the same patient, the spine shows there's a thick sheet of enhancement along the spinal cord, suggesting leptomeningeal enhancement. Now, on MRI, we also have to look at the paraneoplastic syndrome. So patients, small cell lung cancers, we all know, are prone to have paraneoplastic syndromes, and also 10% of non-small cell lung cancers also have a tendency to undergo paraneoplastic syndromes. So this is a classic example of a paraneoplastic syndrome. We see this is a flare image. We see bright areas bilaterally in the limbic system, that is the amygdala as well as the hippocampus, and also in the hypothalamus. So this is a classic case of limbic encephalitis. Now, what are the limitations of MRI? All the contraindications to MRI, like cochlear implants and all, they all have, they are considered as limitations of MRI. Those patients who are claustrophobic, they cannot undergo MRI. And of course, if there is some acute life-threatening feature which needs an emergent scan to be done, then MRI can't be done because it is a time-consuming procedure. So this brings me to the end of my talk. Thank you. Any questions? Yeah. No, so the difference in management is with the location, where it is located, whether you can operate it out or not, and whether the number and the size. The size, number, and whether it can be, I mean, it's amenable to surgery or any form of local therapy or not. Not based on whether it is cystic or solid. But yes, we need to note this down, because from the point of view of response assessment, you know, if previously something was cystic and now it has become solid, that means that definitely there's progression.